Good evening. Thank you for registering and attending this webinar, which will discuss the current challenges in the context of COVID-19 infection control of surfaces in the dental operatory and other areas of the clinical environment. This will include the correct ways to use hypochlorite products and the features of available formulations. My name is Jill Taylor, Head of Dental Education at Austin, and I'm pleased to introduce Emeritus Professor Lawrence Walsh, AO. Professor Walsh is well known. He's a specialist in special needs dentistry who is based in Brisbane, where he served for 36 years on the academic staff of the University of Queensland School of Dentistry, including 21 years as Professor of Dental Science and 10 years as the head of school. Since retiring in December 2020, Laurie has remained active in research work as well as supervising research students at UQ who work in advanced technologies and biomaterials and in clinical microbiology. Laurie has served as Chief Examiner in Microbiology for the RACDS for 21 years and as the editor of the ADA Infection Control Guidelines for 12 years. His published research work includes over 330 journal papers with citations over 15,400 in the literature. Laurie holds patents in 7 families of dental technologies. He is currently ranked in the top 25% of world scientists. Laurie was made an Officer of the Order of Australia in January 2018 and a life member of ADAQ in 2020 in recognition of his contributions to dentistry. I'm sure you will find his webinar informative.
In this lecture, I'm going to explore aspects of surface management, focusing on how to achieve predictable cleaning and disinfection. I'm going to begin by talking about some of the particular challenges that we face in the context of the COVID-19 pandemic, and specifically around contamination from splatter and from aerosolized material. I'll share with you some of our recent research on this topic. Then I'm going to move on to talk about how to achieve predictable management of environmental surfaces, not only in the operatory, but also in other areas of the clinic, focusing on how to get the best performance out of products that combine cleaning with a disinfecting action. Along the way, we'll touch on the regulatory status of claims for activity against SARS-CoV-2, the virus that causes COVID-19. And then we'll go on to look at some of the correct ways to use products, particularly those based on hypochlorous acid. And we'll look at some of the features of available formulations. There's been a lot of information already provided about environmental cleaning in the ADA Infection Control Guidelines, in news bulletin articles that we've written, in other ADA-based resources, and of course, in the 2019 NSMRC Australian Guidelines for the Prevention and Control of Infection in Healthcare. A lot of this information has been digested and aligned for the COVID pandemic and provided for the dental profession through the ADA COVID-19 portal shown here, and I'm sure you're familiar with this site. Effectively, what has been said consistently through all these sources is that we need a structured, risk-based approach to environmental cleaning, and during a pandemic, using a 2-step or a 2-in-1 approach with detergent and disinfectant because of the high risk of transmission of COVID from surface contact. Using a product that is listed on the Australian Register of Therapeutic Goods, the ARTG, with proven claims to inactivate SARS-CoV-2, and applying a consistent approach to all areas that are not only touched by staff, but also are touched by patients, including in the reception area and in the waiting room. In the early versions of the COVID-19 exposure response plan produced in late February and early March, we focused on the need to address not only the clinic but also the reception and waiting areas using disinfectant. Of course, we now know the importance of regularly touched surfaces in public spaces, including things like buttons on elevators and taps in toilets. So we're thinking about everything that relates to what a patient might touch. And this will be continuing on for some period of time, because even though we've now come down to level 1, we haven't gone back to the business as normal that we would all remember from around October in 2019. We're remaining at level 1 and of course following the decision tree from ADA for level 1 patient management. And that includes these more stringent precautions for cleaning and disinfection. Just to summarize the level 1 risk-based precautions: triaging of patients before the appointment by phone and then when on site, designing the scheduling of appointments and the physical facilities of the waiting room to reduce the number of people and to provide social distancing, eliminating objects like magazines that patients would otherwise touch, having patients use hand gel on arrival, during procedures using pre-procedural rinses, dental dam and evacuation, and of course environmental cleaning using detergent and disinfection, either as a combined or as a two-step process, focusing on patient high-touch areas. All of this is based on evidence, and there's been an extensive amount written about the transmission of COVID, including in dental practice, and the Peng and Meng articles are two of the classic papers on that topic. However, the idea of using these risk-based measures is not new to the pandemic. It's been around for quite some time in the NHMRC guidelines, because a structured approach to environmental cleaning removes the source of the infectious agent. And by doing this, it breaks the chain of the transmission of infection. So I'm going to spend a bit of time now just looking at some of the logic behind the structured risk-based approach to environmental cleaning, which is presented in NHMRC. Remember that NHMRC is written for a large hospital environment, and then it needs to be translated through to other practice environments. So in the setting of office-based practice, which of course is where most of dentistry in Australia is practiced, there is an algorithm to follow, and at times when there are infectious agents present that require transmission-based precautions, and that is the case during the COVID-19 pandemic, then in a non-acute setting, which is where dentistry is placed, then it should be detergent solution combined with or followed by disinfectant. And in fact, that was the algorithm even in 2010. So we're thinking about where that would go. It would go on to the contaminated or dirty hard surfaces and the soft surfaces. It would also be used to decontaminate areas such as the clean sink used for hand washing. So there are quite a number of places that you would identify where products of this type need to be used. Obviously, on the dental equipment itself, it's very important to recognize all the different places that contamination could occur. And certainly if you have a so-called continental or over-the-top delivery system, as you'll see when I show you the distribution of splatter, this gets very heavily splattered. And this is one reason why the tubing of handpiece lines is designed to be quite smooth so it can be wiped down. Remember to follow your manufacturer instructions as to exactly how to do that properly. So if we take Appendix 6 from the NHMRC and we translate that into the current situation and look at dentistry under COVID-19, then we can see that we would need to be cleaning the dental chair. We would be needing to address areas like computers and keyboards. If patients are given tablet devices, those things would be included, and we would be using a two-step or a two-in-one process for that. Likewise, things like doorknobs, door handles, hand washing sinks, general benchtop surfaces, telephones, toilets, all those sorts of things. So just to reinforce to you why this is so important, I want to show you some information about how much splatter, droplets, and aerosols are generated by different devices that we use, such as the triplex syringe, the ultrasonic scaler, a particle beam or air polisher, an air turbine handpiece, and a slow-speed handpiece. One way of doing that is to put a visual tracer, such as some disclosing dye, into the coolant water, and you can see how far that goes. But that's actually a very, very simplistic way, because that only shows you the gross splatter, the large particles. If you want to pick up the small particles, you need a much more refined method, and we have developed such a technique. This just shows you setting up the booth where we have the phantom head, and then a couple of positioning devices to allow us to place various types of sensors and detecting pads. In a proof of concept study, we used some fluorescein tracer dye, and using a gel scanning device, we're able to detect nano droplets of this at different types of locations. You can see, for example, the area over the left-hand side of the patient's chest. In this particular example of using an ultrasonic, gets very heavily contaminated, but also there's some material which heads across over towards the assistant. So having spent some time optimizing this model with the ad of a graduate student who was completing their master's in biotechnology, we then went on to do a much more sophisticated analysis using detection pads placed at different locations. And these were able to detect not only micro droplets, but with some optimization down into nano droplets and particles down to a size range of about 1 micron or less. So things that would certainly be in aerosol. The left-hand side shows you the different locations for a high-speed and a triplex syringe used for just 5 seconds. I want you to compare that to the right-hand side panel, which is the low speed and the ultrasonic in the same locations used for 5 minutes. Just shows you the propensity of the high speed and the triplex to produce these sorts of small particles. Now, of course, it's not just using devices that produces such particles. People do that by simply speaking, as well as by coughing and, of course, by sneezing. And we can see here in this famous paper published in the New England Journal of Medicine, the movement of particles from the mouth simply by saying the words, "stay safe." Obviously, if people are speaking loudly or singing or coughing, you get a lot more particles. But the concept here is not just that dental procedures produce particles, that people produce particles every time they breathe. And this is why in the whole concept of environmental decontamination, the thinking has changed from where it used to be and now focus on recognizing where those particles will sit and land, how they will settle out under the influence of gravity and contaminate a whole range of surfaces. Now, we know in the case of COVID how long the SARS-CoV-2 virus will remain viable on different surfaces. For example, on stainless steel, on plastic, etc. And of course, some of those types of surfaces we'll certainly find in the reception and in the waiting room as well as in the operatory. So that also factors into the thinking. If we look at the latest official Australian Department of Health advice issued in December 2020 about cleaning and disinfection of healthcare facilities and also residential aged care, the advice is quite straightforward. To clean the frequently touched surfaces with a two-step, either a combined detergent disinfectant wipe or a detergent wipe followed by a disinfection wipe, and making sure that that wiping process does not spread contamination. So it uses a disposable cloth or a disposable paper towel, and it's done using personal protective equipment. These health department guidelines identify and list a number of frequently touched surfaces: door handles, handrails, tabletops and bench tops, light switches, items which are shared by different members of staff, such as computers and telephones, and of course things like hand washing sinks and bathrooms and toilets and kitchen equipment. There's obviously things that are touched infrequently: blinds, walls, ceilings and floors being examples of those sorts of things. So think about where someone touches when they enter your practice. Where do their hands go? What about those door pushes and grabs and rails and handles, all those sorts of things? Because those things are certainly now very much stressed in terms of high-touch surfaces. Think about places where patients will touch, like elevator buttons and grab rails. Think about places where the staff will touch, like, for example, a FPOS machine or a HICAPS terminal or a cash register. Or what about the coffee machine and the refrigerator in the staff common area, and so on. Let's now move on to look at the safe and effective use of a disinfectant. What are the key steps that we need to get right? Well, one of the first things is to make sure that our product is listed on the ARTG and has established activity against COVID-19. Follow the instructions for use to make sure that the surface is compatible. If we're not using a combined product, but we're doing a two-step, then we need to physically get the surface clean using a detergent. Make sure we understand what the appropriate contact time is for the product. Make sure we're wearing the appropriate PPE, and of course perform hand hygiene before and after the procedure, and of course keep the products safe and out of reach of children. It all comes down to following the manufacturer's instructions for use. If the product needs to be diluted, using the correct dilution, keeping a watch on the expiry date, making sure we've read the safety data sheet, which tells us what to do if there is an accidental exposure, for example, of bare skin to the product. If we're using cloths, to make sure that they're coded so we know which ones are used and which ones are not, and never using a material that comes in a spray directly onto, for example, electrical components or switches because of the risk of electrical shock. The literature on cleaning is extremely large for hospitals and healthcare environments. And if you distill that down, as was done in this excellent paper in the Journal of the Canadian Dental Association, you come up with really three key points: the correct product, the correct protocol, and the correct method of use. The correct product because it needs to be formulated properly in order to be effective. The correct protocol is how you're going to apply and use it. It doesn't matter if you've got the greatest product in the world if it's sitting in the cupboard or it's not being used for the right time or with the right method. And of course, it needs to be applied in a way that is in line with the current pandemic situations. There's no point cleaning and disinfecting on an irregular basis. It needs to be regular. Now, we could spend quite a long time going through each of the 15 or so factors that influence the effectiveness of any disinfection approach. But I thought I might group them into a type of practical way. And you can come back and think about each of these smaller factors later on. But let's sort of think more holistically, at least to begin with. So I've grouped them into a chain, and we're thinking about where the weakest link is that might break that chain. So we've got factors that relate to the clinic. What is the sort of surface? What sort of target organisms are present? Bacteria, viruses, fungi, and so on. The factors in blue are the things that the manufacturer controls. How much is loaded onto the wipe? What is the ratio between the detergent and the disinfection, and how readily is it released? And then there's all the factors in red, which come down to the technique of the user. How often are they doing it? What sort of pressure are they applying when they're doing it? Are they taking the one wipe and then using that across multiple surfaces? And in that case, are they actually inoculating further surfaces as they go? Now, there are many ways that we can assess how well a surface is cleaned. And I hate to disappoint you, but looking visually, which is of course simple and cheap to do, has been shown to not be a reliable measure of cleanliness. Of course, you can do microbial sampling of the surface, and obviously with my interest in clinical microbiology, this is very, very useful to do. But it's not that practical, so we've done some neat work on fluorescent marker systems, which are quite inexpensive and are great because you can covertly drop these onto a surface and then check them afterwards using a long-wave ultraviolet light source. And this is regarded as one of the most practicable methods that can be deployed readily. And so we've written some articles about this in the ADA News Bulletin over the years. There are also techniques such as Atp Bioluminescence, which require you to buy quite an expensive luminometer and some special swabs to go with it. And it only gives you part of the story because you're only picking up the viable bacteria. Now, the idea of using a fluorescence tracer has been in the literature for quite a long period of time. This is a classic paper by a very famous author in the field, John Boyce, where he's just put a blob of fluorescent dye on a surface and then come back later to see if it's been picked up by the wiping. One of the things that is easy to get is a powder called glow germ, which is a type of fluorescent doped melamine powder, extremely fine. It comes in a type of salt shaker. And as we showed in this article in the ADA News Bulletin in 2019, you can just put extremely small amounts on the surface. And if you have a white benchtop, this course the staff will never see it. And if you have a dark benchtop, you can put in just a very small amount, which still won't be able to be seen. But you can see it with a very simple fluorescent tube or LED that is working in the visible violet range. So you come back and you have a look. Here we are just on the side of a hand washing basin. We can see the basin on the left of each image and also this adjacent benchtop. So if the staff have completely missed the area, then you can just see the powder. If they've done one part but not the other, you can see some drag marks where they've been over the surface just once, and of course some powder where they haven't been at all. And if they've not used the right technique, you can just see that the material's just been smeared around rather than picked up. Extremely useful to make sure that you can tune up someone's wiping technique. Because if they wipe the wrong way, they're simply just going to transfer material around the place using the one wipe. And that was shown very nicely in this study in the American Journal of Infection Control, which showed that many common detergent-based wipes weren't that good at picking up surfaces because of the design of the wipe itself. But also staff tended to transfer things from one surface to the other because they used the one wipe for far too long. In this study, they only used it over 3 consecutive surfaces. This is one of the reasons why there's been this trend towards combined detergent disinfectant approaches, particularly in wipes. Which then gets us to the question about the two-step approach or really using a 2-in-1. So we've returned back to those Australian Government Health Department guidelines from December 2020. What do they say? Well, the two-step, of course, is detergent followed by disinfection, and you need to use a TGA-listed hospital-grade disinfection with activity against viruses, or a solution based on a hypochlorous acid, which is a bleach. More about that a little bit later on. Or a 2-in-1, where your combined product is also listed on the ARTG and it has activity against viruses, but it also contains the detergent together. When we think about the regulation of products that are used for surface treatment of healthcare facilities, it's a highly regulated space, and manufacturers can only make claims of activity when those claims have been established with evidence. Now you might see a range of products in the supermarket or in other places which might just be hospital grade disinfectant, but more than enough to handle COVID, but the product may not have a COVID claim. So the COVID claim aspect is quite important in Australia. Another parallel to it is known as the List N from the United States Environmental Protection Agency, which lists the US approved products where there is established evidence for activity against coronavirus. And for example, the Clorox brand of products, which have got sprays and liquids and wipes, etc., have got activity against COVID. In the same way in Australia, you would see an ARTG listed number together with a COVID claim. Now, historically, the first ARTG listed product with anti-COVID activity was Viraclean. There are now over 60 listed products on the ARTG, and they've got there by testing efficacy. Generally, that's not done using SARS-CoV-2 itself. Typically, it's done by using a surrogate target, which is an enveloped virus of similar size and therefore equal difficulty for inactivation. Let me now move on to talk about hypochlorous acid in combination cleaning and disinfection products. One of the reasons why hypochlorous acid is such an important product to understand is because it fulfills many of the desired characteristics of disinfectants. And by modulating the pH and using anti-corrosive additives, it's possible to come up with something which has incredibly good compatibility with different types of surface materials and is non-corrosive, but still is able to work very actively over a very broad spectrum and be quite simple and straightforward to use. Every type of disinfectant product is a balancing act between a whole range of different features. Things that might work extremely quickly might be more likely to show some toxicity towards people if they get in contact with bare skin, for example. So all these things need to be balanced out. This table summarizes the types of disinfectants which are on the market, ranging from alcohols through to povidone iodine and oxygen-based compounds and phenolics and quaternary ammonium compounds, and of course hypochlorous acid sits in the halogen group because it's a derivative of the chlorine type product. It works by denaturing proteins very quickly and therefore disrupting cell membranes, and it has, as you can see, a very broad spectrum. Now, it's not a particularly new idea to use a chlorine derivative, and indeed hypochlorite, common domestic bleach, that type of chemistry has been used in healthcare facilities for a very long period of time. And this is quite a classic review paper from 1997, which looked at the time, the evidence against things like herpes simplex virus, hepatitis A and B, HIV, etc. So the idea is not new. Of course, if you look at the most recent review paper on this topic, published not surprisingly in late 2020, which focuses on environmental disinfection, specifically in the context of COVID-19, you find that sodium hypochlorite and hypochlorous acid, different products from the Clorox company, are things that feature. And they're certainly recognized, as I mentioned earlier, in that EPA List N for suitability for use in a healthcare setting. So you're probably thinking, well, what's the difference between sodium hypochlorite and hypochlorous acid? Well, it's probably easier to think of them as actually being cousin chemicals. So you make sodium hypochlorite by reacting chlorine gas with sodium hydroxide. When you put that into an aqueous environment, it doesn't simply sit there as NaOCl as a molecule. It is highly soluble, as all sodium compounds are, and it dissociates. So we get the hypochlorite ion dissociating away from the sodium. And it's the electron clouds around the hypochlorite bit which are able to attack the proteins. And this is what makes the action of this so effective. So sodium hypochlorite, of course, is the major component in domestic bleach, where its concentration is about 5% by weight, sitting at a pH of around about 11. And that pH is quite important because it affects things like corrosion, chemical reactivity, and also safety if the material gets on your skin. If you've ever had bleach on your bare skin, you'll know it instantly becomes slippery as it begins to break down the proteins on the surface of your skin. This is why it's placarded as being an irritant to the skin. Now, domestic bleach has relatively limited role in modern clinical practice. It is an optional agent after the management of spills, where you've done all of the surface cleaning. Also be aware that domestic bleach can be very, very irritant. If you take any of the typical domestic bleach products and you use them with bare hands, then you not only get problems from the skin being dissolved, you can also get some quite nasty irritant reactions around jewelry. And the right-hand side photograph shows you what happens when someone used some bleach solution that was quite dilute, but they had on a wedding ring and some of the solution got trapped by capillary reaction underneath. You can see it's caused quite a florid reaction. Now, if domestic bleach runs up to about 5%, then obviously industrial levels of bleach can be quite higher in concentration. And I want you to note how the pH has gone up from around about 11 to about 13. And the same is true with the sort of solutions we would use in the laboratory for research as reagents, where again the concentration is higher and you can now see the additional placarding. Our lab has done a large amount of research on sodium hypochlorite and have published about a dozen papers on the topic. And probably two of the most useful beginning papers are shown here. Our chapter on sodium hypochlorite chemistry in the context of its reactions with other agents. This is a chapter in the textbook of antimicrobial agents, and the 2017 review paper on the chemistry of sodium hypochlorite, particularly as it pertains to endodontics, but much more broadly. So let me try to digest a lot of information just into a very simple conceptual slide for you. Why I was mentioning pH before is, in fact, it's all about pH. When you have a pH of 9 and above, then the dominant species is the hypochlorite ion, together with, obviously, hydroxide ions. And that's what's done in things like endodontic irrigants, because at high concentrations of hypochlorite and hydroxide ion, you're able to dissolve soft tissue, like remnants of the dental pulp. So endodontic irrigants are built specifically to have very highly alkaline pHs for exactly that reason. But, and here's the but, the antimicrobial activity is actually better at a lower pH. So at pH values around 6 to 7, the dominant species is not hypochlorite ion, it's hypochlorous acid. And the hypochlorous acid is the little molecule that enters bacterial cells and viruses and oxidizes all the proteins. So there's a bit of a trade-off inherently between antimicrobial activity, which is optimal around about 6, and soft tissue dissolution and irritancy, which obviously occurs at much more alkaline pHs. So the last thing you want to be able to do is to take domestic bleach, which has a high pH, and start splashing that around. You need a product which is optimized in terms of its pH. Now, if you're thinking by dropping the pH it gets better, the answer is not the case, because when the pH gets to below 4, you actually break down the hypochlorous acid into water and chlorine gas, and that's a problem. So the product needs to be stabilized at a pH of around about 6 if you want it to be a good antimicrobial. And that's why you hear mention of hypochlorous acid antibacterial sprays and foggers and so on, because they're pH optimized to be in that range in order to attack the proteins to give it its antimicrobial activity. So in a chemical sense, there's very little or no sodium hypochlorite present at a pH of 6. So it's, as I said, they're like cousins, or if you like, two sides of a Janus coin, where one is present or the other. Now, having said that, let's now unpack the story about Milton Solution. So Milton Solution is a form of sodium hypochlorite, but it's actually much weaker in concentration than domestic bleach. Milton is 2%, whereas domestic bleach is 5% by weight sodium hypochlorite. And if you even just look on the Woolworths online store, you can see there's the 2% concentration stated for you. And note the specific statement, not to be used on therapeutic devices and obviously not to be used in a healthcare setting. Now, the reason I'm labouring this point is that when I audit practices, I often come across the incorrect use of things like Milton or domestic bleach, and I still see people wanting to use it as an endodontic irrigant, and you can't do that. This article from the February 2019 ADA News Bulletin points out the reasons why, including the incorrect formulation, the wrong pH, issues with irritancy, and so on. There's a whole range of regulatory reasons why you do not use domestic bleach or Milton's down in a syringe for endodontics. But there's also some other things to think about chemically. That highly alkaline pH is very relevant to what the material does when it runs into stainless steel. And there's a fair bit of stainless steel and also chrome lurking around a dental practice. The chrome's on the tapware, for example. The stainless steel in the sink or in the chutes, as shown here. So what is the compatibility chemically of highly alkaline sodium hypochlorite with typical stainless steel, what's known as 316L? Well, the answer is not that good. It will definitely start to cause surface degradation. You'll see this terrible black spotting, and if you leave it for a long period of time, you'll get corrosion. And this is a fairly typical example of a stainless steel chemical compatibility chart, flagging the issues around sodium hypochlorite. So that's an issue. However, when you lower the pH down to 6 and when you include some corrosion inhibitors, guess what? It's possible to have a hypochlorous acid product that doesn't interact with chrome or with stainless steel. So it becomes safe for use. And that type of chemistry is now well established. So I've tried to, I guess, explain to you what is different and a bit special about how you can optimize the chemistry of chlorine for antimicrobial activity and how that's different from what's done in domestic bleach, and it's different from what's done in endodontic irrigants. You design it for a specific purpose, and that's one way you get enhanced antiviral activity. And that's certainly what Clorox did in order to tune up products to make them highly effective, not only for antiviral activity, but also for cleaning and for reducing problems with corrosion. So these sorts of products are now available in various sprays, and they're available in impregnated wipes. And these wipes come in different sizes for different purposes. If you like big ones, small ones, etc., for different types of purposes. And the interesting thing is that if you design the right type of matrix for the wipe, you can pick up more material. And when you think about how much it takes to treat a specific area, you can also work out with a well-designed wipe how many wipes you need. And a bit of that research has been done, in this case comparing some of the Clorox wipes to one of the other market leading competitor items, showing that there were fewer wipes that were required because of the better design of the original wipe. All that might be good, but what is the wipe going to do to the surfaces that you're trying to use it against? So Clorox have done some interesting research testing different types of surfaces with different types of agents that are used by soaking, by wiping and then repeating that 180 times, by stressing the material by, for example, drilling a hole near the edge to create cracks and seeing what happens when the material gets a chance to soak in over several days. I'm about to show you the compatibility chart. So they're based on these types of tests. Exposure for 4 days, 180 wipes. What happens when you leave it for 3 days soaking into the material with a broken surface with a hole in it? We can see here that the compatibility against polymers of different sorts, from common ones like acrylic and ABS, and polypropylene and PVC and polycarbonate, for example, is extremely good. Glass is chemically quite an inert material, so not surprisingly, no issues around reactions with glass. When we look at metals, some slight reaction with some forms of aluminium, but nothing in terms of chrome-plated metal or stainless steel 316, which of course are the two most important things you're going to run into. And of course, all those wonderful benchtop materials like corian. So having now talked a bit about all the different things that we can potentially use on surfaces and how to clean surfaces better, etc., I wanted to give you a bit of a thought process around how many things it's possible to reduce touching, the number of people who touch a surface. And there are now various lists that have been compiled around the world because of the pandemic on ways to mitigate touching of surfaces. Now, this doesn't remove the need to clean them. It's just part of a thinking process that reduces the chance for them to act as fomites, inanimate surfaces that spread contamination. And again, you can come back and read through these in great detail later on. But effectively, there's a whole range of ways to reduce how many people touch a particular type of surface. For example, you might have one person who specifically operates a certain thing, like a light switch, or a fax machine, or a printer. For example, I know it's a fairly obvious sort of solution, but often people haven't thought about mitigation. They've just said, well, let's just wipe everything down. Well, there might be ways to also mitigate. And here's a few more. For things like alarm panels, telephones, shared devices, and so on. Finally, I just want to make a few comments about some of the novel methods that are now being considered as part of environmental surface management. You've probably seen some of these used in television coverage and things like that. And this is a very recent review article which looked at the different properties of some of the materials that might be potentially used in a dental clinic during the pandemic. So it covers things like aerosolized peroxide, hypochlorous acid fog, UVC light, gaseous ozone, etc. Really looking at the sort of time that would be required and some of the potential issues around human health. And hypochlorous acid, which has been used in a number of fogging type devices at the correct pH value, as I mentioned earlier, doesn't have significant toxicity issues. That's an important, useful thing to know. It's really all about the right form of the molecule and, of course, the correct pH. So hopefully from this presentation, you've gained a bit of an insight into some of the factors that affect the performance of different products that can be used in surface cleaning, and hopefully you've got some clues into how to do that so much better and more consistently. That's great. So I hope you all learned something from that, and please submit your questions through the question and answer facility, and we'll go through those as they come in. and we'll cover any questions around the topic of environmental cleaning. I've had one that's already come in, so I'm going to tackle that one first, and this will give you a chance to have a bit of a think about any specific questions you've got. The question is, how does a product like Clorox compare to a product like Clinicare? So this is a question of composition. So Clorox, as I've mentioned to you just now, is hypochlorous acid at the optimal pH of around about 6 to give it that antimicrobial activity. Clinicare is a reasonably typical product based on a quaternary ammonium compounds. These are probably the single biggest group of chemicals that are used in existing surface cleaning products. And the particular quat that's used in Clinicare is one called benzethonium chloride. You've probably heard of benzalkonium chloride, which is probably the most commonly used quat, also referred to as BAK. The other interesting ingredient in Clinicare is isopropyl alcohol at low concentration, about 15 to 20%, and the rest is water. So the mechanism is different, the chemistry is different, but the pH is also different. So according to the safety data sheet, the pH of Clinicare is above 10. So it's gone to the alkaline side of things, which is where, as I mentioned before, reactivity and issues like corrosion tend to be much greater at very alkaline pHs, and also at very acidic pHs, so at the extremes of the pH range. And I did have a look at the safety data sheet and the product specifications for Clinicare, and I couldn't find anything about anti-corrosion additives. So I'd be interested to know a little bit more about what the stability of different metal surfaces rather would be with a product like that. At least with Clorox, there is some data around how it reacts with stainless steel and chrome-plated metals and all those sorts of things. And I showed you a couple of those reference tables in the presentation. The other interesting difference between, if you want to pick those two products, is the nozzle in how you deliver them. So the nozzle is much finer with Clinicare, so you notice there's more odor in the air. The nozzle with the Clorox is different, so you get much bigger particles designed to spray onto a pad and actually have less go into the air. So the amount of relative odor is a little bit different as well. So there are quite a few different things that a manufacturer can do to actually tweak some of those different products. And that's just one really good example. So that's a great first question. So thank you for that. Are disinfectants safe to use on soft surfaces such as dental chairs? The answer is it depends. So a number are designed specifically for that purpose, and what they tend to do is they tend to not have ingredients like ethanol. So if you have a lot of ethanol and sometimes isopropanol, that can remove some of the plasticizers from the upholstery, and the upholstery becomes brittle, it begins to crack and split and delaminate and so on. So it's very important to know if a product is designed to be compatible with upholstery. It might be fine on a rigid surface, but may not be okay on upholstery. And you can always check with the manufacturer of your stools or of your dental unit, if you've got them from different places, and see what products they recommend for upholstery, because they might recommend a product that's got an upholstery conditioner in it, which is a slightly different sort of thing. How would you rate Viraclean as a surface disinfectant? Well, it's been tested in Australia quite extensively, and it's a product that's been on the market for a long time. It's widely used and it works very well. We used it in my specialist private practice clinic for a long time. So it's one of those sort of anchor products because the chemistry around that, the benzalkonium chloride formulation, is really well proven. And as I mentioned to you earlier, it's the first product to get a COVID claim in Australia. And when I just quickly checked the list just before tonight, that number of 60 products I mentioned to you is now actually over 70, which is good. Does Cavicide have a similar profile to chloride? So tonight we're talking about chlorine. Of course, chlorine is the element, and free available chlorine is what hypochlorous acid type products use. So chloride is the ion, as in like table salt or isotonic saline. So it doesn't have really anything in the way of antimicrobial activities because it's not an oxidant type chemical. Yeah, the chemistry of Cavicide is not based on a chlorine releasing system. You need to have a hypochlorite, hypochlorous acid type product, or you need to go to another group called chloramines in order to get disinfection. And quite a few chloramines are used in solutions designed to hibernate dental units to stop biofilm growing in their waterline. So they're used reasonably commonly today as well. So that's a great question. Thank you for that. Okay, here's a question about a hypochlorous acid water generator and testing the pH. How could you add an anti-corrosion type product to that? The anti-corrosion additives are normally things like sodium nitrite. They're the most common sort of, but not the only type of anti-corrosion additive which could be included. In some cases, you can get those as tablets, and this was done in order to make them available for some particular autoclaves where the chambers were having issues around corrosion. So some manufacturers produced anti-corrosion tablets that you could actually add in. In terms of stabilizing the hypochlorous acid, hypochlorous acid and hypochlorites have issues with temperature. If you leave them out in the sun and get them hot, that's an issue. But they also have an issue if you leave them for a very, very long period of time. So it's an important question with shelf life. And one of the reasons why we often don't like domestic bleach being used even in a spills kit is the domestic bleach has been sitting around for a long time in a warehouse, then on a supermarket, then it's been sitting in your practice. Often many, many months have gone by. And by the time the day comes when you open the lid, one thing you notice straight away is you can hardly smell any chlorine. And what's happened is almost all the hypochlorite has broken down. And when you test what's left behind, it's basically a solution of sodium chloride, table salt, and sodium hydroxide, Drano. And that's not really going to give you the sort of action that you want. So the pH is a very, very important characteristic because that does drift over time, but there are a number of ways to stabilize it. And in products like Milton, for example, stabilizers have been added in. They've obviously been used in things like Clorox. If you try to make your own hypochlorous acid, when you have no stabilizers at all, that's when you find that is, because it's so reactive, it's much more unstable. So it's all to do with the way you make it and whether you add any stabilizers into it. Can you use things to disinfect impressions? So the ADA guideline says that you can disinfect impressions by spraying them with a detergent, or optionally you can use a detergent combined with a disinfectant. And that latter protocol is used when you've got patients who you know have got multi-resistant organisms, things like Staph aureus, which you often find in patients who've had head and neck cancer, cleft lip and palate, those sorts of things. They'll often harbour Staph aureus that's resistant, and we certainly see those sort of patients in clinic. And we do use products which have got detergent and disinfectant. But the primary requirement is to have a really good detergent surfactant product. So the answer is yes, you can spray it on. The thing you just need to be a little bit sensitive to is that spraying on a product like this doesn't allow you to reuse a disposable impression tray. It still needs to be thrown out. So don't think because you've sprayed something on that's a really good disinfectant that you can scrape out the tray and then use the tray again, because you can't, because that would be reusing a single-use item, which you obviously can't do. Can you discuss spray bottles versus squeeze bottles if you're using two-step cleaning? It's really a question of personal choice. A lot of people like pre-impregnated wipes because you've already got the right amount dosed onto the matrix of the wipe, so it's very straightforward and saves time. Some practices find that if they're using a spray product and the staff tend to spray it around fairly heavily, you notice a lot of odors in the air, and sometimes that gives the practice a particular smell that may not be entirely desirable, or it might smell too clinical to patients. Whereas if you're using wipes, you tend to notice less of a smell. The other issue is that when we did some experiments looking at different types of membrane switches, we found that if people were spraying directly onto them from a spray bottle, there were more issues around moisture ingress than if people were using an impregnated wipe. It comes down to the fluid resistance rating of the membrane switches. what's known as the IP6 or IP7 rating. So it's generally better practice to use a wipe on membrane switches. So those are some of the practical things that make a difference, and it's probably why many people prefer just to use wipes straight out of a container, because it's just so convenient to do that. Okay, here's a question slightly off topic. Is there any recent evidence to support the use or not use of a spittoon for patients to rinse from an infection control point of view? Okay, well, I need to preface my responses by telling you that I'm not a believer in spittoons, and I haven't worked in a facility that's had a spittoon for over 20 years. And I haven't designed clinics that have spittoons because I don't like them. They make ergonomics more difficult. They put the dental assistant in a less favorable position. They make the plumbing more complex. The water usage of the chair goes up, which is an issue if you're using a bottled system. And most importantly, they introduce an interruption because the patient somewhat feels obligated to use it. If you don't have a spittoon, the patient won't feel obligated to use the darn thing, and you can quite comfortably work by just having an empty cup for a patient to spit into and a cup for the patient to rinse from. And in my particular specialty, we'll often have several different liquids of different viscosity because we still have patients who've got dysphagia and swallowing problems. So it's actually much easier for us to use a system of just having some cups rather than having a spittoon. So it is possible to work without a spittoon. And you talk to people who've been through my dental school, the building that you can see behind me in the image. It is possible to work without a spittoon, and you can buy dental chairs that don't have them. And if you are a left-hander, you'll find if you get an overhead light and a spittoonless dental chair, you can actually work easily as a left-hander. So that's something to have a think about. Okay, in the current environment, how long would you provide to clean an average-sized dental room? Well, I've worked in dental suites of sizes from 6 square meters to 14 square meters. So the answer is it depends on how big the room is and how much bench top you've got and where your clean and dirty zones are, and which is obviously design dependent. So there's not like a universal figure. But I'd suggest to you, if your staff are doing that in 1 minute, then they're clearly not doing a good 2-step procedure, because that's simply not enough time to go around to do it properly. And that's where you might want to use the glow germ powder test to see how the staff are going. I think by the time you go around and do a decent job and get the patient out the door and get the next one, you're looking at a couple of minutes anyway. So I'd suggest to you that it needs to be somewhere around the order of 2 to 2.5 minutes. And I think the typical times when I was helping my dental assistant to change over, we were running on about 2.5 to 3 minutes. And we thought that was a reasonably good performance. And that also interacts with the next question, which is a really good question. How many wipes would you recommend? Well, it depends a bit on which size you pick up. So on one of my slides I showed you, for example, for Clorox, there are 3 different sizes. So it depends on which one you pick up, how many you will need. But a really good sort of general rule is don't take one wipe and then use it on a whole bunch of surfaces. And mistake I've seen is the assistants will pick up one wipe and they'll use it on everything. And by the time they've got to the end, they're actually starting to spread contamination around. The rule that's often followed in a hospital is one wipe, one surface, one direction. And you go through quite a few wipes, but a hospital room's a lot bigger normally than a dental operatory. So you need to think about the size of wipe you're using and also how much material is loaded onto the matrix of the wipe so that you don't run dry, basically. How soon does the wipe dry out if the lid is open? It depends on the design of the dispenser, how wide it is basically, and the way the fluid is loaded and how volatile it is. Some wipes contain a number of volatile components. Often it's the fragrances, and those disappear reasonably quickly when the lid is off. And also whether your staff clip the little plastic lid back down on top afterwards. So that varies from product to product. And often I'm testing out products from different manufacturers. And it's one of the things I look out for is how long does it take before a wipe dries out? Because that gives me a bit of a sense as to what the matrix of the wipe is built from. But it does actually vary quite a bit. Okay, here's a good question. Are Clorox wipes only disinfectant or are they dual action? So they do have detergent inside them, and when you look at a wipe, when you use it over a surface, if there is a detergent effect or a surfactancy effect, you'll often see some micro bubbles along the surface as the wipe is being used, which is a subtle way of telling. And you can also put the wipe in a small amount of water and shake it, and you'll soon see the surfactant produce a bubble type effect at the top. But it's an example of a combination wipe. We've had some excellent questions. They're really good. Oh, I love this question from someone who's not prepared to own up, which is even better. What is the place for barriers? So the answer to that question is, it all depends. So if you have a dental chair which was made in Finland or Germany, look at some of the more famous brands of dental German chair, the philosophy that sits behind the chair is actually around disinfection. So they've designed the surfaces to be wiped. They've designed the tubing to be wiped. They've designed the membrane switches to be wiped. So the number of places you would need barriers on such a chair would be very few, if any, when you look at the manufacturer's instructions. Now, if you flick to the other side of the world and you look at dental chairs which are made in North America, look at common brands like ADEC or Pelton and Crane. When you go to the manufacturer's instructions for those things, they say, put a barrier on here, put a barrier on this, put a barrier on that. So they've gone for a different design philosophy. So it's really important to know what the manufacturer of your chair says in their instructions for use. So dig out their manual, look on their website, ask the supplier if you can't easily find it, and follow those instructions, because you don't want to be putting barriers on something that doesn't need it and was designed to be cleaned. And you need to be using the right barriers where barriers are necessary. And often manufacturers will recommend particular types of products to be used with their dental chair. So it's one of those things about just following the instructions and not assuming that the chair you had in that room previously, you treat the same way when you replace it, because as chairs change, even in a model series, the instructions are actually different. Even within one brand of chair, I've seen the instructions vary over years, because as design gets better and ingress-proof switches are developed, more chair manufacturers are going to wipe everything down with less need for barriers. And that's done to try to reduce, green impacts, basically, environmental waste and things like that. So just follow the instructions of your chair. So there's no universal answer. It's actually very device specific, and many people haven't even looked at the instructions for their chair. I find it so useful to go through the instruction manual for a dental chair, because it also tells me things like, how much can this chair lift? And I want to know that, because we see patients in my specialty who are very large individuals, who are very wide individuals. So I need to know whether this chair can lift 300 kilos or 350 or 400 or 500 kilos. It makes a difference. So all those things are tucked away in the instruction manual for the dental chair. So dig it out and find out. Some companies will do a specific brochure just on managing the surfaces. They'll talk about the upholstery. They'll talk about the hard surfaces. So get that information from your supplier or your manufacturer and read through it and follow it to the letter. But that's a great question. Thank you for asking that one. Okay, Jill, I think we've reached the end of the questions. How are we going for time? We're just over. We're just 3 minutes past the hour. Is there any last questions that anyone would like to submit before we draw this to a close? Oh, here's one. Okay, if you don't know what the active ingredients are, they're probably almost certainly just a detergent-based product. There are a lot of products on the market which are just plain ordinary detergent. So if there is a disinfecting action, normally the manufacturer will describe that to you, and they'll often call it hospital grade, because as I mentioned earlier, under the TGA, you do have to have products registered that have disinfectant claims in Australia. So if it doesn't say disinfectant, then you can't assume it's got disinfectant. You have to assume it's just detergent based. And there are lots of plain detergent wipes on the market. So yeah, which is good. Thank you for that question. Oh, Jill, we've had some excellent questions. This has been really good.
Well, it's been very educational, Laurie. Thank you so much for your time.
Oh, pleasure.
Thank you to all the attendees for attending this valuable webinar. If anybody would like a copy, please email me, jill.taylor, Tayler is the spelling, ausdent.com. Thank you very much, everybody, and thank you, Laurie.
Pleasure. Thank you. Okay, thank you, Jill, and good night, everybody.